Welcome everyone to today's webinar, 10 Practices for Supporting Family Caregivers. I am Brian Zimmerman, Senior Director, Client Content Strategy with Becker's Healthcare. On behalf of Becker's, thank you for joining us. So before we begin, I'm going to walk through just a few quick housekeeping instructions. We'll begin today's webinar with a panel discussion, and we'll have time at the end for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see there on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Today's session is being recorded and will also be available on aarp.org/healthcareprofessionals. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. The hashtag we're using for today's discussion is #MoreThanAVisitor. Please use it in your social media to help raise the importance of integrating family caregivers into the hospital experience. So today we are fortunate to be joined by healthcare leaders and experts who offer a unique perspective on supporting family caregivers. Our panel of experts includes innovative leaders who are implementing, researching, and piloting forward-thinking policies and practices that support family caregivers in visitation policies, age-friendly practices, palliative care, and more. We're joined by Dr. Susan Reinhardt, Senior Vice President and Director of the AARP Public Policy Institute. Dr. Reinhardt is also the Chief Strategist at the Center to Champion Nursing in America and Family Caregiving Initiatives. Susan is a nationally recognized expert in health and long-term care policy with extensive experience in conducting, directing, and translating research into action to promote policy change. Previously, she served as professor and co-director of Rutgers Center for State Health Policy. She also served as Deputy Commissioner of the New Jersey Department of Health and Senior Services, where she led the development of policies and nationally recognized programs for family caregiving, consumer choice, and community-based care options. Also joining us today is Dr. Alan Burling, President and Chief Nursing Officer of Sparrow Hospital in Lansing, Michigan. Dr. Burling has built his 30-year career in healthcare as a clinician, teacher, and executive at many medical institutions. For several years, he was Executive Vice President at Harris Health's Lyndon B. Johnson Hospital, the busiest Level 3 trauma center in the nation. Dr. Burling and his team at Sparrow made national news in late 2020 for their innovative visitation policy, allowing COVID-19 patients to visit with loved ones in person with PPE, leading the way in patient and family-centered care. Next, we're joined by Dr. Tamron Gray, an instructor at the Harvard Medical School. She is also a health services researcher at Dana-Farber Cancer Institute and the Brigham and Women's Hospital. Dr. Gray's research focuses on the needs of family caregivers who are most vulnerable. She is particularly interested in developing solutions that spur health system and policy changes to leverage patient and family-centered care, palliative care, and care transitions as innovation points to improve health outcomes, health equity, quality, and costs. Finally, we're joined by Dr. Deborah Stamps, Vice President, Chief Nursing Education Officer at Rochester Regional Health. Deborah's career with what is now Rochester Regional Health spans 3 decades. In her role, she works to build on and operationalize Rochester Regional's commitment to diversity, inclusion, and equity. She also works directly with clinical leaders to continually improve the system's overall performance and ensure patient safety. She's a leader in nursing education as well, building partnerships with local colleges to increase the number of students choosing nursing careers and supporting the expansion and diversity of the Isabella Graham Hart School of Practical Nursing. Thank you all for being with us today. I'm going to transition over now to Dr. Susan Reinhardt, who will set the stage with some introductory comments before we jump into some questions.
Thanks. And hello to all of you. I'm honored to be on this distinguished panel and so happy to be with you today because you really are the healthcare leaders who can change the experience for family caregivers and for those that they support, your patients. And I really mean that from the bottom of my heart. I am a nurse and I have practiced in both hospitals and home care. So I've known for a very long time, as I'm sure you do, that people we serve are embedded in their families and communities. I want to start by saying that I know that some family relationships are complicated and that not everybody has a family caregiver who helps them. But the term family caregiver for us at AARP is very broad. We include family members, neighbors, friends, frankly, anyone who provides support to a person who needs and accepts that support. And when these family caregivers are trying to help people with very complex care needs, they themselves need our help because our patients don't live in hospitals, as you know. They go home with their health conditions and their treatments that they and their family caregivers are expected to perform, sometimes for days, but often for much longer than that. I've been focused on the relationship between clinicians, healthcare professionals, and patients and their families for many years through direct practice teaching, research, policy. And I came to the ARP Public Policy Institute to really try to advance creative policy solutions and systems change, something that I know you all know about, systems change. That's really what we're trying to do here. The Public Policy Institute is what I like to call the think and do tank of ARP, and I hope you know that ARP exists as the largest national nonprofit, nonpartisan organization with nearly 40 million members, so real people. And ARP has made family caregiving a top priority for several years. So who are family caregivers and why would ARP make this such a priority? There are more than 40 million family caregivers in the United States, providing 37 billion hours of care to the tune of $375 billion in free care. It's no longer the average family caregiver, the 48-year-old white female taking care of her 78-year-old white mother. It's much more complicated, much more diverse than this in many different ways. Family caregiving cuts across gender, age, and race and ethnicity. Not just women, 40% are men, so let's hear it for the men. Multicultural groups are over-indexed, and 1 in 4 is a millennial or a Gen Z, and you may not be expecting that. You may not notice that younger person right there next to the person that happens to be in the bed. In 2012, I conducted the first national research of family caregivers with my colleague, Carol Levine. We wanted to better understand the kinds of complex care that these family caregivers were given, and even more important, how they learned to do it. We call that study Home Alone because we found that half of them, 20 million family caregivers, are doing complex care, things like managing multiple medications, including injections, wound care, special diets, ventilators, catheters, all kinds of things at home. And they said that they received little instruction from anyone in or outside of the hospital, even about medications. About 7 out of 10 said they had to learn at least some of the medications on their own, which really surprised me. Most caregivers are working, yet they provide an average of 20 hours per week on tasks that are often very complex. They often say they have, in fact, half of them say they had no choice. That doesn't mean they won't want to do it, but who else is going to do it if I don't? And they worry about making mistakes. And COVID-19 has only exacerbated these challenges. This research led to the CARE Act, Caregiver Advise, Record, and Enable Act. Our ARP state offices brought this research to those members I talked about, who overwhelmingly embraced it as their own experience. They didn't need the numbers. They knew what they had been experiencing for years. And since 2014, they have urged passage of the CARE Act in 44 states and DC and are still working in the other states to get it passed. So basically, we have a national law, state from state, that requires hospitals to ask every patient that is admitted, regardless of age or diagnosis, if they have someone who's going to help them, a family caregiver. If so, do they want that person recorded in the medical record? And if they say yes to that, that person must be offered instruction for what they're expected to do after discharge. And they're supposed to be told when that discharge will take place as soon as possible, because frankly, 8 out of 10 family caregivers get less than 24 hours of notice of discharge. I conducted a follow-up study 2 years ago, in 2019, again with several colleagues as co-authors. We call it Home Alone Revisited, and we found that family caregivers are still not getting enough instruction support. And that's why it's good to talk to you today, because you can change this in your systems. So today we're going to offer resources to help you do that. We offer a 10-part series of promising practice we call Supporting Family Caregivers Providing Complex Care. These guides are based on a national scan. We went to hospitals and health systems across the country after this research, and they're based on real work in the field, things that you, perhaps yourselves, are doing. It impressed us, and we think that you will find it helpful. I want to acknowledge my co-authors, Heather Young, Rita Shula, Karen Drinkard, and Beth Sora, and also our funders, the John A. Hartford Foundation, the Ralph C. Wilson Jr. Foundation, and the ARP Foundation. So we're going to highlight these 10 promising practices with my colleagues on this panel. You can find them at arp.org/healthcareprofessionals. I'll turn it back to you, Brian.
Thank you so much, Susan. Truly appreciate it. And it is a great honor to be a part of this. As a former family caregiver myself, you mentioned 40 million people out there are family caregivers. This is truly an issue that touches everyone and is not elevated enough. So it's a pleasure to be a part of this. So as Susan mentioned, we're going to break this down into 10 practices for supporting family caregivers. And practice one that we're going to dive into is invest in training your staff about supporting family caregivers. So Deborah, I'm going to turn to you for my first question. In your experience, how has training your staff on sort of recognizing and supporting family caregivers influenced the patient experience and also, the business of hospital care?
Thank you so much. And thank you again for this opportunity to speak with so many of our colleagues across the country. Just to start out, Rochester Regional Health is a large health system in upstate New York. We have 9 acute care hospitals, and it's really an integrated delivery system where we look at the patient experience from entry from the community into the hospitals or post-acute services, ambulatory services, and so forth. Training and education really starts with fulfilling our mission for the organization. Patient-centered care is key. And we know today that many of our patients have extended families, families that, may be more on the traditional side. However, there are many people that are providing caregiving to various individuals. From a staffing, healthcare provider, interdisciplinary team perspective, it's imperative that we train and educate and set the expectation that the family caregiver is part of the care team. That's first and foremost. In doing so, we know that decreases anxiety for the patient and the caregiver, that they are included, their voice is heard, and they're able to make contributions to the care of the patient overall. It really is important as we train and educate members of the team that we actually use simulation. Some of our residency programs partner with our Nursing Institute to provide these types of trainings. In our nursing school, where we have 2 nursing programs, we actually speak about and educate to the fact of patients being at the center of what we do, and their family is part of that center. It's also really important that this impacts the patient experience overall. And we know that patients and families will choose where they go for care based on the experience that they have. That's really the business case for inclusion of the patients, their families, their caregivers. The patient experience is really enhanced. It ensures trust and communication when the hospital or post-acute care team are working closely with the families. When a patient is in the hospital, for instance, they're at their most vulnerable state. And COVID actually highlighted that increased stress when caregivers were not able to visit as regularly as they would have prior to COVID. Our families had to advocate virtually, and so educating and supporting the clinical staff to be able to support those needs was integral during COVID. Excuse me. We also know from that families face the need for caring, and not only for the patient or their loved one, but also for themselves. We know that caregiver burnout is very high. So how we as healthcare professionals, the interdisciplinary team, can help support them, answer their questions, decrease the disruption, be ready to address their feelings. This is a very emotional time when you have a loved one that requires care. So really looking to educate the team in various ways so that they can then in turn support the family caregivers as well as the rest of the interdisciplinary team in providing the optimal care to the patient.
Thank you so much, Deborah. A quick follow-up for you. In terms of the staff experience, the clinician experience, would you say that this training and this engagement that you're sort of empowering them to have with families enhances their experience as well?
Absolutely. In healthcare, it's really all about collaboration and teamwork. and realizing how the caregivers can also be an integral part of the team is really important, supporting the work of the frontline staff. Absolutely.
Excellent. Thank you so much, Deborah. We're gonna move now to practice 2, which is offer education to family caregivers. Alan, I want to turn to you for this next question and just ask, how does Sparrow Hospital sort of approach supporting family caregiver through education, and how have you observed these efforts sort of influence the patient experience?
Well, thanks for asking the question. Thanks for having us here. You know, it's interesting. Throughout COVID, we've all had to learn to do things differently than we would have ever done before. And what we've seen, especially in light of the fact that so many procedures are going to an outpatient environment, 10 years ago, we wouldn't have dreamed of doing a total knee or a total hip in, a same-day surgery center. And today, that's common. And so just this morning, we had conversations about the other procedures that we see going to the outpatient environment, where traditionally we would have kept the patient overnight or for 2 or 3 days. Today, it's come in, get seen, and go home. So what we do today is very different than what we've seen in the past. And probably most notably is we begin the education process almost as soon as the patient touches our healthcare system. And so when we get them into the pre-anesthesia testing centers and we do the pre-op work, we're teaching there. The physician office is teaching there. Of course, we're doing the things that many people do, joint camps and things like that. But that now applies to almost every single outpatient procedure. So from the outpatient environment, we begin very early on. We've actually seen some of our marketing actually shift to reflect that notion. So from the outpatient side of this and the elective procedures, we're certainly seeing some big changes. And on the inpatient side, of course, the standard things, because the inpatient environments oftentimes are more emergent or unexpected, we find ourselves doing a tremendous amount of education with patients and families. And it got mentioned in a previous conversation that oftentimes these are virtual. And so we're doing that a lot with patients. We're reaching out via iPads and cell phones and other software programs that we've employed, particularly for patients who are in the intensive care units, reaching out to their families and doing as much education as possible along the way. Certainly every time a nurse goes into a room and provides medication for the patient, they're doing instruction at that point in time. And we want to include the family members, the caregivers in that. And I'll tell you, I am a member of AARP and have been for quite some time and very happy to say so. One of the things I think that I have seen used even on me, which I thought was fantastic, was when the provider said to my spouse, "Would you like to take a recording of me doing the discharge instructions for your husband before we send them home?" And so what then occurred is, using our own cell phone, we took a video of the discharge instructions, very clean, very crisp, read somewhat from a script, but articulated and explained in such a way that we kept that video for the next 3 weeks and referred back to it. Oh, what did that doctor say? What was I supposed to do about this? And so we find that to be perhaps one of the simplest, easiest means for educating, family members and caregivers and giving them the opportunity to really capture in the moment. Plus, it gathers the emotion and the empathy and the sympathy of the physicians and the providers and the staff. And so that's really a very good overall perspective and a way to capture in a simple fashion discharge instructions and then make those available. And of course, with that, we go over all the numbers to call, et cetera. And so if you had to ask what the impact of this has been on the patient experience, I would tell you it's been fairly positive. It's one thing we try and get down to a one-pager of here's your discharge instructions, but oftentimes that's very difficult because of some of the legalese we have to go through. But if we can boilerplate it, get it down to a few lines written, then we turn around and we have the opportunity for capturing on video. We've seen our patient satisfaction go up from that. And of course, the other thing that we do here is we try and get as many patients as possible to our discharge lounge, which allows one final time to really go over everything together and transition the patient to home. So we're trying several things here all at once. understanding that if our patients understand their discharge instructions, the caregivers understand what we're trying to achieve, then we'll have a much better experience for the patient, and quite frankly, we'll end up with a healthier community, which is really important. And we certainly push all the elements around vaccination and mask wearing and social distancing as required, and really trying to give our patients as good an honest, objective, scientific perspective, and really give everybody a full opportunity to ask us questions in an environment that is very open and allows for that to occur. So we're seeing some positive movement from this with patient experience as well. But at the end of the day, this is really about helping our patients not only get through their healthcare process acutely, but also stay out of the hospital in the future. Because quite frankly, this is one of those businesses where we're glad to see you, we wish you weren't here, kind of thing.
Absolutely. Thank you for sharing that, Alan. I think especially struck by the example of taking a video on your phone. You're using a tool that a lot of folks already just have on them, and doing it in a way that's impactful. Thank you for sharing that. I want to move to practice 3 now, which is prioritize communication and care coordination. And Tamron, I'm going to turn to you with a question, which is I know your research is sort of focused on improving care delivery and outcomes for patients with serious illness, and improving that experience for their caregivers as well, of course. For those patients, the family caregivers are often coping with complications and unexpected outcomes, right? So not to mention just the stress and financial pressure they may feel on top of that entire experience caring for somebody with a complicated illness. How does communication with the family caregiver play a role in patient outcomes, do you think?
Well, that's a great question. Thank you so much for that question. First, I'd like to say I'm so excited and delighted to be here today, a part of this important conversation. We all know that this is so important. No surprise to this audience that family members are really the glue. They're a central piece of the puzzle. And I think that goes right into a perfect segue into this issue of communication. So what the evidence tells us first is we know that family members play a pivotal part in healthcare settings, long-term care services, and supports for individuals with serious illnesses. We also know that they tend to the psychological and physical aspects of one's care. But when we think about communication and how that impacts coordination, evidence shows that poor coordination of care has negative consequences for patients and contributes to higher medical costs. And what better way to mitigate some of that by including those who are often overlooked and invisible, which are the family caregivers. These family caregivers are close loved ones. They intimately know the patient. They know the patient's goals, preferences. They also have an idea of what the person would want if they aren't able to speak for themselves. So if we engage family caregivers, we're able to really understand and hopefully prevent some crises that could arise in terms of care delivery and care coordination. For instance, family members may have perspective about the financial and time commitments related to caring for someone after discharge. If the family member, says we can't afford this medication, that's important knowledge to know, because it's not only going to impact adherence, but it's going to impact the patient's health outcomes for the care that's hopefully being managed. We also know that the National Quality Forum really they aim to promote effective communication and coordination and care across health systems. So by including family members, which are already a part of the healthcare team, which we should be a part of the healthcare team, we know that they help to improve accountability. They help to transfer knowledge and information. They also help to promote continuity of care as the patient's moving in and out to different systems. They also generally, when we communicate with family members, we know that they tend to have a pile of patient information in a binder, on the tablet, on the phone. So just being able to have someone who has that information readily when technology otherwise may fail us is really important. And then lastly, being able to know who to contact in place of different emergencies, being able to know before a crisis happens who the family member is that we've been able to partner with them, engage them, inform them early on. It's really going to help reduce negative consequences later on. But I think, my main point that I want to get across is that we know that the evidence says effective communication helps to improve patient safety and satisfaction. We also know that the role of things like family meetings have been well studied in intensive care, palliative care, and pediatrics in particular. And what these studies have shown is that family meetings, when done proactively in a structured fashion, really does provide the opportunity to ask questions, address perspectives of the illness to hopefully offset some anxiety, depression, and unpreparedness that family caregivers may have. And when we think about family meetings in general, the clear and effective communications about the patient's care are really useful in being able to hopefully meet their goals of care and have optimal outcomes for patients. So family caregivers are the central they're the central piece of the healthcare system, and they're a constant for the patient. So they absolutely must be engaged in communication.
Yeah, absolutely. Communication is so important, and they're a conduit, right, from the patient to the health system. Thank you so much, Tamarin. And we're tracking just a little over time, but Susan, before we move to the next point, I'm wondering if you could put you on the spot here, maybe in about 60 seconds or so, if you could share a preview of some of the top communication practices you observed from the national scan of hospitals sort of implementing the CARE Act, as you mentioned at the top.
Yeah, we have a whole promising practices on this with like 10 communication enhancements. I think the key is to try to make it routinized into the system. You just heard, for example, Tamarin talking about these huddles. Very, very important, this change of shift. Not just accidentally the person is there, but really planning for the person to be there. Or as Alan said, use technology, bring them in on their cell phones or some other way, because there's such information that can be given. I like to just share one, and that's to give the family caregiver a name tag. And one system told us about this, the name tag, because they are staff, basically. They're part of the team. And when they have that on, they could get a discount both in the cafeteria and the gift shop, just as staff did. So that's a good marketing tool too.
Absolutely. Thank you for sharing that so much. We're going to move now to practice 4, which is standardized family caregiver data in the EHR. And Deborah, I'm going to turn to you with my next question. So I know your system recently finalized sort of an affiliate agreement with St. Lawrence, which is a 3-hospital system, and a key component of that partnership was shared access to your EHR. So can you share how you prioritize including family caregivers in the EHR, and if you've observed how including them impacts the care experience for providers, patients, and of course, those family caregivers as well?
Thank you so much. Absolutely. As an integrated health care delivery system, and thinking about the distance between Rochester, our main hospital, and St. Lawrence, the electronic medical record becomes integral, ensuring that we have accurate information about the patient, but also who the caregiver is, ensuring that we have appropriate contact information, whether it's cell phone, that we're able to reach out, and even do video or telemedicine type visits when the patients are at a distance. It really is about optimally providing care that is safe, high quality, and is inclusive of the family caregiver. Having one record and one system, regardless of where the patient is. As a large geographic, fully integrated health system, the patient's records remain whole. So as the patient may transition from one hospital to another, the loss of who their caregiver is does not occur. It's really important, as we have various members of the interdisciplinary team caring for patients, that we know who that caregiver is. It's also really important as we look to facilitate continuity of care post-discharge. Who are we doing, providing the education? Who are we providing the information about medications or discharge care? It's really important that the staff know who to contact as far as a family caregiver. It really is important when you think about medications, something as simple as medications. The family caregiver knows the most about the patient. And so ensuring that there's no loss of information when it comes to the care, and also vice versa, going back when the patient is ready for discharge. And it's really about, regardless of where the patient receives care, that the family care team is able to access, for instance, the patient portal. For instance, we call that My Care. And so having information from the healthcare provider, the health team, their lab work, their next visits, all being in one record is very helpful and decreases anxiety and stress. We also have a process where what's called our transitions of care, where we have care managers that follow up with patients following their visit. They can also connect with their family healthcare provider, giver as well. And that also helps to decrease, ensures that there's no questions about their medication, the treatment plan, and ensuring that they have the follow-up appointments as needed.
Excellent. Thank you so much, Deborah. Tamron, I know you have a unique perspective on this as well, so I want to give you some time to speak to this, and because I know some of your research is focused on utilizing novel methods from computer science to document the family caregiver in the EHR. Can you share how family documentation might support improved health outcomes and the uptake of supportive services, thinking for both patients and the families, really?
Absolutely. Thank you so much for that question. So an important research study that I'm leading really focuses on, like you said, using novel machine learning methods to assess the documentation of family members in the electronic health record. And as mentioned earlier, family caregivers are overlooked by the system, meaning there's often not enough resources, supports, and trainings for their role, particularly as they face different stressors. And one of the fundamental reasons why I decided to conduct this research study is to be able to better identify, assess, and support family caregivers starting at the time of hospitalization and hospital discharge, which is an important inflection point for many caregivers. It's often when they become caregivers because they have to go home with the patient. When it comes to hospital discharge, there's so many moving pieces and parts, especially when it comes to the responsibilities at hand. And two major problems that my research hopes to really look at and address is it's really promoting a standard way to identify family caregivers when they're coming in and prior to discharge. And then second, a consistent way to support them once the patient leaves the hospital. So bottom line, caregivers need to feel prepared in order to provide quality care for their loved one. And the first step is really to acknowledge their role and address any unmet supportive and palliative care needs across settings. And this particular study really is looking at it's really addressing the fragmentation that we have in healthcare. So with the support of the Cambria Health Foundation and the Rob Wood Johnson Foundation, I'm addressing this problem by looking at 5 different hospitals in my state. And we're seeking to understand how caregivers are identified and their potential to extend palliative care and other support services into the communities. When we have the documentation of who the caregivers are and what potential social determinants of health patients are facing before they leave, the goal is really to promote triggers, to really ping community centers, community resources, so that patients and families have what they need when they get discharged, so they don't come back unnecessarily. But really the goal is also to continue that continuity of who the caregivers are when they're in the hospital and then when they are back in the community. So really the goal is just to kind of see how can we promote continuity of care and how can we assess triggers for what patients and families need when they go to the hospital.
Thank you so much for sharing a bit about your research with us. I think that the thing that you said that stuck out to me, standard ways to identify caregivers and consistent ways to support them. I think that is a very succinct way to put it in and conceptualize it. I want to jump to practice 5 now, which is focus on transitions in care and post-discharge support. Susan, I want to turn back to you to talk more about, what you've learned through the national scan. What are some of the difficulties family caregivers face, especially during transitions of care, and maybe some of the consequences of leaving family caregivers sort of unprepared to deliver the care they have to at home?
Well, I think the most important thing is they don't feel confident. If they don't get these instructions, it's really, they're nervous and the patient feels that. It's not a good situation. They feel burdened. I don't like that term. They feel stressed. They feel guilty. It's not a good scene if you're not prepared. And I want to say that this transitional planning, although we do have special programs for people at high risk for readmission which is a good thing. Everybody needs transitional planning. Everybody. I mean, my sister just went through this with her husband. She's a registered nurse herself. You still need that kind of preparation. I really liked what Alan said too. This isn't only a hospital admission, where you're going to be there for days. This is outpatient surgery, etc. People need to be engaged from pre-admission through admission, through the hospital stay and post-discharge. Through, I like what he said about increasing the instruction that can be going on. People should be prepared emotionally and practically prepared for what's going to happen. So if they're going to need equipment, for example, they should know that ahead of time. And there are some tips that we give in these sheets about how that happens. It doesn't help to give them a piece of paper and say, get this equipment as they're walking out the door, because what are they going to do? Leave the person alone while they go get this? And how are they going to afford it? This really all has to be planned up front. Medications, materials for wound care. People have to have that already. And it's not good to leave this at the very end when people are already distracted and the logistics of going home. When you do this throughout the admissions, teach back, as Alan said, talking about medications every time you give them, etc., then people can digest it in smaller bits. And I love the idea of having your cell phone, pull it out and take these pictures. It's really important. We have found that it's really important to have collaboration among nurses and social workers, for example, because they look at different things, and the patient and family caregiver needs both. They need that medical complex care kinds of things, but they need connections to the community resources for aftercare. So having both, and I also do love that idea of the discharge or the transition suite, not the old school discharge suite where people were generally parked, so to speak, waiting for someone to pick them up. This is an intervention that can be accomplished with nurses on staff generally, and then also a pharmacist coming and reviewing all the medications. That will increase the caregiver's confidence and skill level, frankly, which will reduce anxiety and promote healing for the patient.
Absolutely. Important point, too, at the top there you made about sort of everybody. No one's immune to this. Everybody needs this support who's in this position. Thank you for sharing that. I'm going to jump now to practice 6, which is lead practice and system change. And Alan, I think you're a perfect person to speak to this. Sort of at the top, I mentioned how Sparrow Hospital sort of, received major national news attention when you decide to allow COVID-19 patients to have one in-person visitor. Can you share how that one change influenced the care experience for all involved? And are there other practice and systems changes that emerged during this crisis time that you'd like to continue? Alan, you may be on mute still. I'm not hearing you.
And so I owe you $1. Sorry about that.
Okay.
So, we had an issue, and I think most hospitals did early on, that we really did not understand how devastating isolation could be. And quite frankly, we were going through a series of deaths in our intensive care units that were tough on families. They couldn't see their loved ones. Clearly, it was the worst way we thought for a patient to experience the end of life, drowning for weeks and then ending your life and alone. And our nurses were stepping into the gap, and we realized that this wasn't the best for anybody. So we created a methodology where we allowed a visitor. We met him in the lobby. We put a PAPR on him, a self-contained breathing device, as well, a PAPR, and we brought him upstairs, gowned them, gloved them, got them into the room, let them see their loved ones. The impact was almost immediate. We obviously had patients who'd been isolated and alone for sometimes weeks, in tears, their family members in tears. One of our own nurses was not allowed to see her father until we made this process change. And so that was significant. Probably the most significant moment of all was an emergency room physician who came to me and he said, "Thank you so much for what you did about visitation, and it's made a world of difference in my life." And I looked at him and I said, "Well, I don't understand. You're an ER doc. Help me understand this." And he says, "Every time I admitted a patient, I would tell their family member, say goodbye, tell them you love them because you may not see them again." He said, "I don't have to have that conversation anymore. it's no longer a worry. I can't tell you the emotional burden you've lifted off of my chest. And what we saw were our caregivers experiencing the exact same things. Our nurses no longer were the sole individual in there. The family really could be there. And I have no scientific data to back it up, but I will tell you that I believe our death rates dropped because we are not meant to be alone. And at that point in life, we certainly are not meant to be alone. So we took a stance. We've been doing it for a year now. It's changed everything about how we approach COVID. It certainly has changed everything about how we approach the need for caregivers to be involved. We had isolated them. I think it was it was what we didn't know, but we fixed it and we got it better. And so I think we'll always have that mentality of trying to do the right thing. It's moral authority leadership. We just want to do the right thing, and then how do you make it work? So that's going to be there. I think if you look at other things that we've done that will never go away, we can't get rid of our drive-through testing and our drive-through vaccination clinics ever. It's Michigan. The weather gets really, really cold. We've got a model worked out where you never have to get out of your car. That's for certain going to be something that's with us forever. We will never go away from some of the technology we're using now that we've taken from our intensive care units and put it into our neonatal intensive care units, right? So grandparents can see their grandchildren in a neonatal intensive care unit. So I think those things will be there forever. And I do think the social determinants of health came up earlier. We've started work on food insecurity here. I think that is a real challenge for the elderly population. And I think that's something we have to do a much better job at. So we've got some initiatives headed around that I believe we will foster and maintain for a long time to come. COVID has forced us to be innovative, and that's a great thing. There's always a silver lining, and if anything we've learned is that we can do more with what we have than we ever expected, but it's up to us to figure out the problem and solve it before somebody tells us it's a problem. And so that's the approach we're trying to take.
Thank you, Alan. I truly appreciate you sharing that with our attendees today. It's great to hear about that sort of any silver linings throughout this harrowing experience that all of you have been working through. So really appreciate that. We are running tight on time, so I'm going to move right to practice 7, and I'm going to challenge our panelists to be succinct as they can be, so we can make sure we hit all these 10 practices and have a little bit of time at the end of the hour for some Q&A. So I'm going to turn now to you, Deborah. Can you share any ways Rochester Regional has innovated to help family caregivers prepare to manage medications at home? Our practice 7, of course, is Innovate in the Pharmacy.
Yes, thank you so much. And no pressure for me. There's so many practices that we've implemented over the last year and a half, 2 years. And one of them is really through our communication center, ensuring that we have integrated navigation where a nurse does a follow-up call with patients from discharge within 48 hours. It also allows, while patients are in the hospital and their caregivers, because really discharge planning, especially around medication, starts at admission. And you really have to start educating about the side effects, how medications are given, and so on and so forth. And that really starts from discharge. What also happens is that there's a pharmacist that works with the family and patient while they're in the hospital. When they're discharged, an outpatient pharmacist works with the family. And so, for instance, we have a congestive heart failure team of where we have a pharmacist that actually works one-on-one with the primary caregiver and the patient. In addition to that, ensuring the use of technology. We saw the use of technology over the past year, iPads, utilizing Zoom to really help connect face-to-face when you couldn't be in person for these the patients and their families. The other piece that's really important from a medication perspective is also when our patients are discharged, we give them their meds upon discharge. So they don't have to run around to a pharmacy and figure out insurance and things like that. That is really taken care of as one less step upon discharge. We also ensure that we have in our discharge lounges where nurses are able to go in and provide that one-on-one education to the patients and their families as well. Again, reinforcing a lot of the strategies and the interactions and the indications for the medications that really start upon admission. These practices have been proven to reduce readmissions and emergency department utilization, as well as decrease cost of care over time.
Thank you so much, Deborah. Really appreciate it. And we're going to jump right to practice 8 now, which is implement strategic screening practices. And Tamron, I want to ask you, I know some of your research is focused specifically on the deeper demands that caring for someone with incurable cancer, for example, puts on a family caregiver. I believe your research found that more than half of caregivers have misconceptions about the patient's prognosis. How do you think better screening of family caregivers leads to more supportive care for those with deeper needs? And what do you think are some effective strategic practices that you can share with our attendees today?
Well, that's a big question, Brian. Thank you so much for that. I'll be brief in my response. I really want to have a few takeaways for the audience today. And in terms of your first question, how do I think this leads to better, how do I think screening of family caregivers leads to more supportive care? Honestly, it's about knowing who's at risk. What we know is certain health conditions that patients have put caregivers at potential risk for burden and distress, higher burden and distress. So knowing, who are the patients that the family members are caring for? So therefore, who may be at risk? People with incurable cancers, incurable diseases, with chronic conditions that really are degenerative over time or progressive over time, that have high physical burden. We know that when patients are not doing well physically, caregivers will not do well physically. They're very interdependent. So knowing who's at risk in terms of caregivers, and that's based on the patient's health information. Asking questions. One of my studies is looking at screening for bone marrow transplant caregivers. And what we're looking at is how do we assess their needs over time during the transplant process? So asking questions, not just at the beginning, but throughout, because as the patient may get sicker or healthier, the caregiver's experiences may change and their risk for certain outcomes may change. And also just seeing them, meeting them where they are. So when it comes to these screenings, we don't necessarily always know what we'll find that the caregiver uncovers. But we have to be ready to respond to their physical, psychological, emotional needs. And then finally, what do you think are some effective screening practices? I think we need to use a combination of things. Patient-reported outcomes, caregiver-reported outcomes, when we ask them specifically about their anxiety, their depression, their mood overall, their well-being. But also EHR data prediction tools. We have technology and data at our fingertips. We need to be able to build a story around the patient's health in the EHR and see what may put the caregiver at risk. Then also looking at the patient health data in terms of, how are they doing from a medical standpoint and how they may impact caregivers. And then finally, looking at narrative notes from social work and nursing and other members of the healthcare team to really draw upon potential conclusions that this caregiver is at risk for different levels of distress and suffering. So I think using everything in our toolbox, knowing who may be at risk and asking questions, assessing often, are some of my takeaways, I would say, for practice 8.
Thank you so much, Tamron, for jumping through that. Appreciate it. And I want to jump right back to Deborah for practice 9, which is address the needs of specific populations. COVID-19 really preyed upon some longstanding health inequities in our nation. And I know, Deborah, that health equity is a big part of the work you do. So I want to ask, how do you prioritize addressing the needs of family caregivers from diverse communities?
Great. Thank you so much. It first starts with the healthcare team having an understanding and a solid foundation of some key principles. The first one being health equity. The principle of health equity is really having that underlying commitment to reduce and ultimately eliminate healthcare disparities. We actually saw with COVID-19 that the work that has been done for many years around healthcare disparities has not afforded us the elimination or the reduction in many cases. it's really important that we have standard foundational definitions. For instance, diversity. Diversity is really the mere presence of difference. We also know that those various differences are driven by various dimensions of identity. We know that equity is creating opportunities for giving equal access to underrepresented groups. However, not everything is equal, right? There's equity and then there's equal. Inclusion is really about being active, intentional, and ongoing when it comes to diversity. And I love Werner Myers, the CDO Netflix officer, really says that diversity is being asked to the party, but inclusion is being asked to dance. And we know that the evolution of diversity really aligns with patients and caregivers in the fact that as care providers, we have to have cultural humility. We're no longer able to be competent. Competence really suggests that it's a once and done. I had a training, now I'm competent. Cultural humility really speaks to being humble and respectful around individuals who are from other cultures, realizing that we possibly can't know everything, and then being really culturally responsive. It's the mindset that affirms that we own our own culture while really engaging in those cultures that are different from us. It's really about ensuring that we have foundational education and understanding from our care teams and being able to understand some of the drivers of these health equities. There's many structural drivers. In healthcare, the patient comes to us when they're at their most vulnerable, sickest state. But we also have an opportunity to impact that care when you think about unhealthy communities, structural drivers such as transportation or access to healthy foods, and even personal traumas impact. And so really being able to be willing to listen to where our patients are, to really talk about the challenges that they may have and how that may impact them is really integral. For us, and just to share one brief story, as we led our community with COVID community conversations back in November, December of last year, I wanted to really get out to the Latinx community. And so speaking in Spanish was really important. We had healthcare providers that could speak to our patients in Spanish. And for me, someone who doesn't speak Spanish, and to listen to how the dialogue went and planning really opened our eyes as to really seeing from their lens, when someone does not speak the language, the primary language that you speak, how difficult it is to understand and how we can lose things in translation. And that actually led us to work with our marketing and communications team, and we're able to actually translate with a click of a button our website into more than 200 languages to meet the needs of our community. And so it really is about listening, experiencing, seeing from that lens where we can meet people where they are and help not only provide the health and wellness, but also the support to their caregivers, being that resource to them and connecting the dots in so many ways.
It sounds like it really is about seeing the whole person, and you probably can't be patient-centric without doing that work. I appreciate that. And something else that stuck with me is, I think, cultural humility and culturally responsive. Those two phrases, I think a lot of folks will take away from this. So appreciate that. I want to jump to practice 10 now. And Susan, I am going to put you on the spot here. So the practice 10 has championed the CARE Act. And I have a question for you, Susan, but also, we've had audience questions come in. We've only got a handful of minutes left. And one of them is specifically referencing the CARE Act. So I'm going to pair these two questions to you and see if you can answer both of them in one fell swoop. So Susan, my question for you is, how do you see the CARE Act benefiting healthcare organizations? And then the attendees question is, they're seeing a lot of movement towards the hospital at home model. And how do you see the implementation of the CARE Act changing and influencing hospital care at home? So two-parter there for myself and an attendee.
Okay. So I told you earlier that most family caregivers said they were worried about making a mistake. The CARE Act should be designed or implemented in a way that helps them not make a mistake. We know that mistakes happen in healthcare. And if you don't know the basics, then you're probably making some mistakes. So safety is a big part of this. feeling empowered, feeling confident, as I've said, for the hospital, it actually can improve your metrics. We had one report, for example, that for HCAHPS, those HCAHPS scores, 10% increase in the response to the question, do you get information you need at discharge? 10% increase. And in the nursing domain, up by 5%. This is money. This in a value-based system. These are real important metrics. I know we shouldn't be just worried about metrics, but they're reflecting what people are actually experiencing. So reducing discharge delays, unnecessary readmissions, which are costly, and improving safety and continuity of care. Hospital at home, this is a common sense bill. It's just like common sense. So people say, why do you need it? Well, we need it because we weren't doing it. So yeah, we need it. And hospital at home should be following these same tenets that you've just heard from these fabulous colleagues on this panel. First of all, I would like to know, were family caregivers asked if they wanted to be part of this? I don't think many patients are at home alone for hospital at home. There's got to be somebody around if they need that kind of care. So are we asking them? Are they involved in the admission process? Same kinds of questions. What do they need to learn? Are they worried, et cetera, et cetera? I'm actually starting a new study. Rita Shula, who's on the phone, and I are starting a study to actually explore this. What are the protocols for hospital and home, and to what extent are family caregivers engaged? Because they really need to be.
Thank you so much, Susan. You're a real champ for being able to pair those two together so succinctly, so appreciate that. I'm going to jump to another question from an attendee, and as a reminder to folks out there, any questions we haven't got to, I know Becker's and AARP on the back end will be happy to engage with you and make connections. But this attendee asks, do you feel healthcare professionals are more open to being recorded? I think this is perhaps in reference to a story from Alan. Sometimes visiting nurses are not truly familiar with devices, i.e. wound vac. But I'll put that one out there. Do you feel more healthcare professionals are open to being recorded?
So, I think Alan or Debbie are one of them. Alan?
Yeah, absolutely. I think we're getting better at that. When you think about it, every one of us carries around a camera every day. And so I think we're getting there. I do think it's important for healthcare organizations as they're thinking through this to make sure their legal departments are aware of what's going on, and then stick to the script, right? This is not the time to ad lib. This is the time to go through it, explain it, and answer simple questions, but you really don't want to go in there and wing it, right? So I think we're getting better at it. We're going to want to do it more. And quite frankly, this is the wave of the future. And every time you do anything online, anytime you use technology, you can be recorded whether or not you know it. And so I think it's really important that we be thoughtful about that and not trying to ad lib, but really trying to be thoughtful about our answers up front.
Thank you, Alan. I'm going to throw one more question out there before I sign this off. I think it's a good one to close on. The attendee asks, is there a template for caregiver support to follow for consistency in educating, providing discharge instruction to be used for standard and consistency?
We are not creating such a standard template. I think that there should be flexibility within organizations, how their workflow processes, what makes sense. So we have not created a standard template.
Thank you, Susan. And that will conclude today's webinar. It was a pleasure speaking with all of you, and thank you to some great engagement from attendees. So again, our panel, thank you so much. AARP, thank you so much for sponsoring this and allowing me to be a part of it. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today. We hope you have a wonderful afternoon.
Thank you.